So I know that a large part of this has already been touched upon, and I think this is a burning area in aplastic anemia, the clonal evolution and what it actually stands for. And there's much to be uncovered even as now. So just what is clonal evolution? So it's actually a phenomenon in which a hematopoietic progenitor stem progenitor cell gains a growth advantage, and most commonly due to acquired genetic changes, a growth advantage, or you may call it as a survival advantage, which the culmination of which is the expansion of a clonal population with one or more of these somatic mutations. What was very beautifully brought out through the day, especially by Dr. Neil Young, that it's a non-neoplastic condition. This is very important to understand. It is not synonymous with neoplasia. And it is seen very commonly. Now it is shown that 12.5% of individuals overall and more than 50% above the age of 80 years will have a clonal hematopoiesis. So, and you know, these people continue to live. So if it was malignant, they would not have lived. Though there is an increased risk of hematological malignancies in these patients. And the clonal hematopoiesis in aplastic anemia is frequently accompanied by somatic mutations, which are seen in myeloid malignancies. So this is kind of a background. This is one of the early papers which was published in New England Journal of Medicine in 2014, where this was a study which was done in Sweden, and we all know that the population registries in Sweden are impeccable. You know, you can follow up patients for 20 years or more. You know, I personally have that experience because I've done a PhD from Sweden, where I used to see that they give a lot of sanctity to human samples. So the mean age of these patients was 55 years, and they were followed up for 2 to 7 years. And this is how they found that it was observed at that time. You have to understand the techniques which were available at that time. They found that the mutations were overall observed in 10% of the persons older than 65 years of age. And these were the most frequent mutations which are seen: the DNMT3A, ESXL1, and TET2. So this was one of the early papers, and now, of course, with the next generation sequencing, you know, the highly sensitive, this has become more evident. So this is what I was trying to say. With the advances in the next generation genome analysis technology, you know, with the SNPs, with the single nucleotide polymorphism assays, with targeted NGS, and with the whole exome sequencing, and an MHC region NGS, it's important to note that there is a near ubiquitous presence of clonal hematopoiesis. It is present in almost 70% of all aplastic anemia patients. And even in the pediatric patients, it is seen in 60% of the patients. And in adults, it may be almost 80 to 100%. So this has come with these very targeted sequencing techniques. And this again has been discussed through the day, that as we know that aplastic anemia is an immune insult in the bone marrow. And actually that immune insult does not just lead to an aplasia, but it also promotes a clonal hematopoiesis. The immune stress itself can lead to somatic mutations. And on the other hand, you can have a selection of clones which have an advantage to be selected over those which are eliminated by the immune attack. And what ends up is a clonal hematopoiesis. And PNH, if you can see, is in about 20 to 25% of the patients, and MDS, AML in about 15 to 20%. Again, these are some of the major NGS studies of clonal hematopoiesis in acquired aplastic anemia. And if you see the last column, the percentage of patients with MDS-associated mutations is quite high. So coming on to the landscape of clonal hematopoiesis in aplastic anemia. As I said, it can be seen in 70 to 80% of the aplastic anemia patients. And the two most common somatic changes which are seen is the mutation of the PIGA gene and the loss of the HLA class 1 alleles. And both are pathognomonic of immune-mediated marrow failure. So it's not surprising to have these two most common somatic changes. And actually, the copy number neutral loss of the heterozygosity of chromosome arm 6p is quite specific to aplastic anemia. And what is interesting is that the PIGA and the HLA mutations are not found concomitantly in the same clone. In addition, about 10% of the aplastic anemia patients will also develop some cytogenetic abnormalities. And if one looks at the part B, that the good risk somatic mutations are the PIGA-A and the BCOR and BCOR-L1. And the good cytogenetic aberrations, alterations are the deletion in 13q and trisomy of 8. Whereas the poor risk somatic mutations are those of ASXL1, RUNX, splicing factors, and CBL. And the poor risk cytogenetic abnormalities is deletion 7, which we all are aware of, and the complex cytogenetics. And what is again interesting is that unlike, the deletion of the chromosome 7 or a partial loss, monosomy 7, it is also seen in MDS. But what is different from in MDS, you usually find it in conjunction with either TP53 mutation or with a complex karyotype. But in aplastic anemia, it is typically an isolated abnormality. And here I've tried to show that the somatic mutations seen in aplastic anemia, as I said, are quite different from what you will see in MDS and quite different from what is seen in an aging population. The aging-related clonal hematopoiesis. So there is a different signature of the mutations, of the somatic mutations seen in aplastic anemia vis-a-vis those of MDS and an aging hematopoiesis. So coming to now, what will promote the evolution of aplastic anemia to a secondary MDS and AML? And it's not a very simple story. It's a kind of a complex story. It's not just the nature of the mutations, but it is much, much more than that. And the first most important thing is that this is promoted with the duration of the disease. If you see by 5 to 6 years of age, by 5 to 6 years of the disease duration, there is an evolution of about 4 to 8%. But by 10 years, this reaches about, in different series, 9% to 26% by 10 years. So the duration of the disease is very important. And the second is the age. It's much lower in the pediatric population. It's only 2% at a median follow-up of 5 years. Then is the role of the somatic mutations. The earlier one detects the mutations, especially at diagnosis or in the ensuing 6 months, and the allelic fraction of these mutations will again be a risk factor for the development of secondary MDS or AML, the early occurrence and at a high allelic burden. So it's not just the type of the somatic mutations, but it's many more factors. And, it's the duration, and it's the earlier in the onset of the disease that these mutations are detected. And then, as we all know, that the monosomy 7 is a very bad prognostic cytogenetic change, which is normally associated with an adverse prognosis, very poor response to immunosuppressive therapy, high relapse rates, high rate of evolution to secondary MDS and AML. And as I already highlighted, that contrary to MDS, you can see it in MDS also, it is normally not associated with TP53 mutation or with a complex karyotype. And this is just highlighting how an HLA class 1 allele deletion promotes the clonal evolution. You have the antigen, which is presented with the class 1 molecule to the cytotoxic T lymphocytes. And if you have a loss of the HLA class 1 alleles, the deletion of these HSPs will not occur by the cytotoxic T lymphocytes, and then they will proliferate. So certain HLA class 1 alleles, there's a higher risk for the MDS-associated clonal hematopoiesis, which I think Dr. Neil Young touched in his lectures, one of his lectures, the 1402, HLA-B 1402 and HLA-B 4002. And their somatic loss, as already shown in this diagram, provides a growth advantage to the hematopoietic stem cell progenitors. And then the telomere attrition. This is different from the inherited telomere shortening. That as we know that the shorter is the telomere, the more severe is going to be the disease course, and there'll be more frequent cytogenetic evolution. And what is interesting is the telomere length in the lymphocyte compartment is associated with T lymphocyte activation. So a more severe disease, and the immune insult is also important for the senescence and telomere attrition. So what is the link of this clonal evolution to some of the drugs which are used for the treatment of aplastic anemia? Initially, it was shown that GCSF, this is a Japanese study which showed that the use of GCSF, this is a study where it was on 50 children treated with cyclosporin and recombinant human GCSF. And 11 of these were shown to develop an MDS/AML, and 8 of these within 6 months, much earlier than the previous reports. And 10 of these children showed monosomy 7. Contrary to the rest, 41 children, they did not develop MDS/AML. And this is another study showing the same kind of data with GCSF and without GCSF. However, I haven't quoted all the reports, but this has not been shown in the randomized trial. And this is one of these randomized trials which has got published, where it's from the EBMT, Severe Aplastic Anemia Working Party trial from the EBMT, where there's no difference in the PNH, in the evolution of these cytogenetic abnormalities and evolution of PNH with or without the use of GCSF. The same story about Eltrumbobag, and this actually is an area for future research and for future observations also, that there is, and this data was shown in the morning, that when you give EPAC for at least 24 weeks, it may result in the rapid emergence of abnormal metaphases, but not in the expansion of clones which have the somatic mutations in the myeloid candidate genes. So it may promote the expansion of dormant pre-existing clones with an aberrant karyotype. And this is the same paper, and this is a recent study from Dr. Neil Young's group published in Blood 2022. And a total, it's a study, patients were accrued from 2012 to 20, with a total of 178 subjects. And they did not show the clonal evolution was 15% in all the treated patients at 4 years. Did not, the last line, if you see, it did not occur at a higher rate than it was observed in a historical cohort, but the median time to the evolution was earlier in the immunosuppressive therapy and EPAC treated patients. So this is the kind that we have to be, this needs a further evaluation. And this is a recent paper which has got published for pediatric patients, though in pediatric patients, the role of EPAG of eltrombopag is really not known, is questioned now. But the same kind of thing, same kind of data, that the clonal evolution was 13% in the IST plus EPAG group versus 9% in the IST group. So, but again, as I said, this needs a further and a long-term follow-up. This is one study which has shown that the predictors, strong predictors of the chromosomal aberrations and myeloid neoplasia following the immunosuppressive therapy for severe aplastic anemia. It's a retrospective cohort study where age of more than 48 years, a diagnosis and a pre-treatment ANC of more than 8.7 were strong predictors of a high-risk clonal evolution. But the comparison of the EPAG with IST versus IST showed that the clonal evolution was same, but an increase when all the high-risk clonal evolution was the same, but an increase when all clonal evolutions were considered. This is another thing which I wanted to highlight. This is something that, which is something new in this paper, that the detectable, we know detectable mutations precede the late myeloid neoplasia and aplastic anemia. And in this, there's a 58 high-risk clonal evolutions of 666 subjects treated with IST. 58 had a high-risk clonal. This is just the high-risk clonal evolution. And you can see majority occurred within 5 years, before 5 years. And the most common was chromosome 7. But what is very interesting in this paper is that there were 4 patients who had a non-7, without 7 chromosomal abnormalities at the time, when they developed the secondary MDS and AML. So it's something much more than what we understand at the moment. The biology part is much less than what is much more than what we actually understand. And therefore, and this is the last, this is a patient who actually went from population 1 to population 2 to population 3 to population 4. It's one case. So they picked up 4 cases which did not have the chromosome 7 abnormality. So if I look at the perspectives of all this on clonal hematopoiesis and somatic mutations in aplastic anemia, yes, there is a growing evidence of clonal hematopoiesis and somatic mutations in aplastic anemia, especially with the highly sensitive next generation sequencing techniques. And it's not just the nature of mutations which determine the subsequent evolution to secondary AML, to secondary MDS or AML, but many more factors. As I said, the disease duration and older age, a disease which responds very poorly to therapy or which relapses back, factors which accelerate the telomere attrition, and of course, the genetic alterations. So as of today, if we look at the clinical implications, maybe a close follow-up of the high-risk patients. And as a clinician, whatever is the available data, as I said, high risk for the high-risk patients, especially I think tomorrow it's being covered, the role of upfront alternate donor transplants in patients. So with the high risk, one can start thinking of a revision in the sequencing of the treatment options. People who have a complete deletion or a partial deletion of chromosome 7, may be good candidates for an upfront transplant. Another area to be studied very carefully is the TPO mimetic drugs, TPO mimetic drugs and the clonal evolution. I think much more data and a more long-term follow-up of these patients is needed. A lot more is going to follow in the years to come, which will shed more light into the biology and the clinical implications of all these somatic mutations, the interaction with the immune environment of the marrow, etc. But this is an opening, and at least some clinical applications are evident. Thank you.